Okay, good morning. I think we're live at this point. Thank you for joining the Healthcare Roundtable for Somerset. We see that lots of you have dialed in and logged on, and that is great. So we're thrilled that you can join us for a little while this afternoon. My name is Kara Wieckowski. I'm a senior consultant with Somerset, and I'm going to act today as our moderator. We have with us in the room here today Mike McCaslin and Jeff Boomershine, both principals with our group, and they have lots of experience and lots of knowledge in strategic planning to share with us today. I want to remind you of a couple things as we go forward as far as the webinar. The first is that we don't have slides for you today. Instead, we just have a couple intro pages. You are welcome to stare at our faces on those intro pages as long as you like. However, we don't have other slides for you to follow along. So this is really based on an audio panel discussion. And then I also want to let you know that you may give us questions to answer that we'll address at the end. And the way to do those would be to type them into the box that says chat on the right side of your online panel. So again, you're welcome to add questions to the chat box, and we'll address those after Mike and Jeff have a chance to answer some of our questions. My focus today, of course, is strategic planning. Both Mike and Jeff have led many healthcare teams through the strategic planning process. And as we're still new in the year of 2012, we thought it'd be a good idea to focus on what's in a strategic plan and how do they go well. I will ask Jeff and Mike their questions about their perspective and experience, and then we'll allow time for questions at the end. So as we get started, I'll start with Mike. Mike, can you tell us a little bit about what makes up a good strategic plan?
Thanks, Kara. Good morning, everyone. When looking at trying to put together a strategic plan, we think obviously there needs to be some structure and formality to the process and approach. So whether we look at health system or physicians or whatever the organization is, we basically look at 7 categories for which we think most strategic planning initiatives fall under. And the ordering of the categories is really a function of what's going on in your organization, what pressures are you feeling, what's happening in your marketplace. And again, we define marketplace as it could be a 2-mile radius around your primary location, because in many places that's all that matters because of what a physician group may be doing or what a hospital may be doing in that area. So first thing, and the first focal point area we look at is your mission, vision, values, philosophy. Oftentimes in the physician world, we look at that pretty quickly, and it's more of a ratification process to make sure, first off in the planning process, that yes, our mission hasn't changed, our vision of what we want to be when we mature, grow up, whatever the right phrase is still the same. Our philosophy, our culture, and so that's in the health hospital system world, a lot of emphasis. In the physician world, while it's just as important as in any other world, it's not necessarily a place where in the physician world we get a lot of good feelings spending time in that area. So ratification process there. Next focal point is growth. How are we going to grow our practice? That growth may be by providers, physician providers, ancillary providers, complementary service providers, ancillary services, and within the growth strategy, how are we going to market those services, and then what markets should we be providing those services in? So some pretty significant elements under the growth strategy, a substantial and critical area in most practices. Growth is actually, in some groups, part of their culture, meaning we're going to constantly grow, we're going to constantly grow by providers, grow by market share, grow by geographic territory, patient population covered, et cetera. The third category or focal point is alignment. And growth and alignment really have jumped to the forefront in 2011 and 2012. And alignment is really alignment with other healthcare organizations. So it could be hospital alignment with other hospitals, hospital alignment with physicians. In the physician world, it's the same. It could be physician alignment with other physicians, whether that's merger or some other type of structure or some other type of joint venture model that may be physician to physician and those physicians with some type of hospital alignment strategy. It could be your group's alignment strategy with hospitals in your marketplace. It could be your group's alignment strategy with payers. As payers look at innovative models for looking at paying for care in different models other than a fee-for-service model, looking at risk-based or risk-sharing models, and looking at longer-term contracts, then we look at, okay, how am I going to be aligned with payers? What do I need to be doing there? And obviously then we could have health system to payer alignment strategies. How do we work collectively to improve the quality and reduce the cost of the population that we serve? And that typically takes partnering. The next category would be quality as a focal point. And again, I would tell you maybe 3 years ago this would never have probably come up in a planning process, but now when you look at what's coming out of Washington, coming out of ACOs, coming out of WellPoint Anthem in the last week over what they're doing with primary care, looking at what other payers are doing. And the interesting thing about quality is it's kind of it's that mirage that you see on the road on a hot day when you're looking down the road, because everybody can talk about it, but we're still struggling to say what does it actually mean. And it's going to have meaning because when you look at achieving incentives in an ACO concept, or when you look at what payers are doing to be innovative, criteria number one to be eligible is meet all the quality metrics, meet all the quality criteria. So we have to begin the discussion. There's government issues, there's clinical issues, there's risk-based issues, there's cost data, and then the simplest category is the patient satisfaction survey data. And, you know, we have to get the process, and sometimes your first stage is just to plant the seed that we're going to get there. And the longer range process on the physician side is how are we going to bake this into our economic model? And on the hospital side is how are we going to get the partnership, or the health system side, how are we going to get partnerships with our physicians, because we can't achieve what we're after unless we have those partnerships. Next focal point is really physician specific, and that is how are things working on the physician side of the equation when we're planning. And that typically includes, does our governance work? Does it need changed? Have we grown? Has the group changed? You know, are we consistent with our mission and vision and value and philosophies in terms of how we want to govern the group? It deals with our organizational structure. It deals with, do our buy-in and buy-out facilitate recruitment in the environment we're in where it's hyper-competitive, especially in the specialty world, to be able to attract and recruit a physician. So have we really taken a step back and made sure we're competitive, that we're able to deal with what's happening in the health system world of offering jobs and what's happening with the other physician marketplace-based entities that are offering jobs. We have obviously compensation formula issues. Unfortunately, this is a pretty hot topic in most groups right now that deals with revenue allocation, expense allocation, ancillary allocation, metrics for allocation, just a whole host of issues. There's a fair amount of issues dealing with the transition to a completely electronic work environment. And is the overhead methodologies previously utilized that looked at a people-based work environment versus a technology-based work environment still appropriate in terms of what we call fixed and variable expenses? And so there's a pretty big block of issues there to be tackled, so to speak. And then we have issues related to how hard I want to practice, what's the rewards for practicing in a slowdown model, and other things related to call, et cetera. So you've got the physician issues, we have succession planning issues, am I training and developing younger people to serve an executive committee and leadership roles in the practice? What models do we have in place? What internal and external resources do we have to make sure we have the right people involved? And obviously, checking in on is our code of conduct, our physician covenant, practice covenant, are those things up to date on what we have as commitments between physicians and the organization and physicians, and quite frankly, those same things apply within a hospital. Next category is operational excellence. there's a tendency to not think operations are tied to planning, but quite frankly, all strategy can only be executed if operations perform at the highest level. So it's really important that we're looking at all the areas of our operations. We're looking at workflow. We're looking at efficiency. We're looking at cycle times. We're looking at collecting a dollar, matching up our reimbursement with contractual obligations from outside parties, et cetera. So there's a broad array of operational excellence categories that lead to planning initiatives. And the last category is our facilities. Are our facilities up to date? Do they lead to an efficient practice? Are they good for the patients? Are they in the right locations? Do we need to own? Should we lease? Do we need to own some and lease some? And so that is the last category in terms of focal areas that we think are a part of the elements of a good strategic plan. And therefore, organizing around those categories and then making action-oriented decisions around those categories is what we think the planning process and strategic planning is all about.
Yeah, so within each of those focal points, you would then have several initiatives that would help you get there, right? So
correct. There would be many potential initiatives within each of those focal points. What we find out over time is for those who are new to the planning process, the initial planning process will lead to a large number of initiatives, a large number of tactics, and over time, as you are involved in an annual planning process, then the number of initiatives starts to pull back because of all the accomplishments you've made year over year.
Yeah, okay, all right. Jeff, tell us a little bit about who you involve in this planning process and how you might pull them together.
Thank you, Kara, and good morning, everyone. We like to view the strategic planning process as really a living and breathing process that you go through. Oftentimes groups will go through a strategic planning process, come up with a document or an action plan and put it on a shelf, and then think about it maybe 6 months or 12 months later. So it really is a document and a process by which you really try to drive your strategies for the year, stay on track, and really involve the entire organization. So you really do have to have top-down involvement as well as bottom-up involvement as you put a plan together. So obviously your physicians and your groups have to be a part of that process, but you also have to involve everyone from middle management down to office managers and all the way down to what we call the frontline folks in your billing offices and your medical assistants and those that really are involved in operations. Oftentimes they see where the difficulties are, where the frustrations and inefficiencies are as you go through some operational improvement, and getting their input is very important to getting buy-in ultimately for your end product or your strategic plan and what some of your initiatives or tactics might be. A lot of this is also dependent upon the size of your group and the span of control that you have in place with numbers of managers in different areas. Smaller groups, obviously, you can involve practically everyone in the development as well as execution of strategic planning initiatives in a process. Larger organizations, you typically would have more of your manager-level folks involved in, in these planning sessions. That would ultimately involve everyone in the group, but the planning is more at a manager level. I think we'll also talk a little bit about the process and going through the retreats and how you actually put together these plans looking out for the next year or longer term period of time. But again, I think probably the biggest driver and who all is involved in creating a plan is the size of your organization. And an important comment is making sure that you've got input from everyone that's actually involved in executing on these strategies and initiatives.
Okay, thanks, Jeff. So we've heard a little bit about what goes into the plan and who should be involved. Mike, can you tell us how you actually do that? You know, how do you start gaining consensus? How do you pull the group together and actually start drafting a plan?
That's a good question, and I think I'll follow up on Jeff's comment about group size because I think the group size dictates different approaches. In a larger group structure, and let's say that's 35 to 40 doctors and up, and maybe in the 30 range, you're really going to look to senior management and potentially a strategic planning ad hoc group or the executive committee to really go about the process of constructing a proposed plan. a proposed set of initiatives that could be constructed in the focal point structure that we've identified. And this group would spend their 2 or 3 month period identifying each goal, each strategy, each tactic to be followed, combining that into a plan itself, and then at a planning session, submit that to the physicians as a whole, more as a communication of where we're headed, seeking approval and maybe some tweaking, but not necessarily facilitating the plan from scratch in that setting, because I've used my senior leadership team to build it and now present it. So in a large group structure, that's really going to be the most effective approach. In a smaller group structure, and that's anywhere from 15 to maybe that 30 level, what we're likely looking at is a process that, and by the way, the large group structure could also include this, but a process that's going to engage physicians through either interviews, or we tend to think a questionnaire process is more efficient, an online questionnaire, because it keeps the physicians focused. They type their answers. We don't get off on tangents that interviews often do. And the questionnaire could be either general, if we're not certain of all the areas we need to cover, or it could be very specific. You could have a retreat based completely on growth and alignment, and so all questions would deal with a physician or an institution's thought on where do we need to grow, who do we need to align with. So that questionnaire, as well as other market intelligence that might be gathered, or we may determine in the planning process that we have to go get market intelligence, would really be built and constructed in terms of an agenda, a set of topics for discussion that would then be a Saturday retreat or a Friday evening, Saturday retreat structure where you would engage the entire group in a discussion over the categories by focal point and what action plan the group should come out of that particular meeting with on each one of those categories. Now, in taking it the next step then, once the physicians have agreed, management typically might have a follow-up management retreat saying, here is the initiatives that the physicians agreed to, what are our operational or management team initiatives to support the initiatives that the physicians came out with. So we may have a month after the physician weekend retreat, a management half-day or full-day retreat to build our own plan that supports the plan that the physicians came out with. And so we kind of marry those two up in a smaller organization in that structure. So it's really the size dictates that process. Again, the best way we've found to involve physicians on the physician planning process is questionnaires, and then that may be followed up with some phone interviews.
Okay, that makes sense.
And I could also add to that a little bit as well, Kara. Especially for the larger groups, a tool that is often very helpful is utilizing an online survey, such as SurveyMonkey or KeySurvey. I believe we use KeySurvey primarily. It's a good way to poll the group. It doesn't have to be just once a year or once every other year when you're doing your strategic plan, but oftentimes when there's a variety of issues you're trying to get group input on, especially in their larger groups where you don't often get everybody all together on a regular basis. Utilizing the online survey tools is a great way to give everybody a chance to provide their input. Everybody feels like they've had a chance to voice their opinions. And then those survey tools also provide a nice mechanism or way of summarizing those responses, getting some graphs or charts back out to the physicians, and letting everybody know what the poll or pulse of the group is on those particular issues.
Okay, good. So that allows you to pull together a lot of information in a quick time frame, but yet hear from all your constituents.
And it's oftentimes much more efficient than just sending out general emails and getting a wide variety of responses that include, I don't really care about all those, but what I do care about is X. So.
Yeah. It's hard to know, too, when somebody grabs you in the hallway and says, this is absolutely our top issue. You don't know how that weighs in with the rest of the group. So the survey allows that chance to, weigh it in with the rest of the group. You mentioned, you're doing this survey or checking in with the constituents, at the 1 year mark. Now, some groups will do like a 3 to 5 year plan. Are there benefits to doing it every year, or what do you suggest, Jeff?
A very good point that we often get questions not only from physician groups but also hospitals, and time frames vary quite a bit between what physician groups are doing and what hospitals are doing. We joke internally that a long-term plan for a physician group is sometimes looking 1 month out because things are changing so rapidly and there's a lot going on in the physician world. We believe it really is imperative to address it at least annually, and oftentimes, again, going back to that living and breathing process and document point, you're making changes on the fly to your strategic plan even as you go throughout the year, reacting to competitor actions, reacting to your hospitals and the health systems, in addition to reacting to what's going on with the federal government. And just as one point, the last several years, we've all been on pins and needles a little bit waiting to see if the sustainable growth rate cut with Medicare gets fixed. And some groups have gone as far as to do some preliminary planning as to what they would do if we get that 30% cut in Medicare reimbursement, although we really do not expect to see that happen short of having a social revolt in the United States. We do expect to see the SGR get fixed, but it's just an example of how you really cannot put together just a 3 or 5 year plan and not really readdress that at least annually. So most of the groups that we work with are doing annual plans. Some are longer-term initiatives such as system alignment or new facilities development. Obviously have longer development time frames. It takes longer than that to build a building, obviously, but selecting those markets, working on system alignment, definitely longer-term strategies, but many of the operational issues and many of the physician issues, which can include revisions to compensation plans, group culture issues, governance as you grow and start to expand into satellite or super satellite type of models, and of course everybody's favorite call coverage often gets readdressed on a regular basis.
Okay. Mike, as you think about, the plan gets built, then how do you make sure it gets followed?
Well, that's a good question because we invest time, you invest in outsiders to facilitate, you invest a weekend of somebody's time, and then, you want to make sure that all of that investment has a payoff. First is how you document what you're going to do. And we're very task-driven, so everything we do really has an issue, an action item, a responsible party, a targeted due date, a definition of resources needed, and it looks pretty simple. We don't necessarily produce a big binder that sits on a shelf. You may have 5-page Excel spreadsheet that basically lays out everything you're supposed to do with a results column. And so the best way to make sure that it gets followed is once a month, and it really is a function of how often you have your executive committee meetings, but the planning, the action plan needs to be on the agenda for the executive committee, and at the quarterly shareholder meeting or the every other month shareholder meeting, the action plan needs to be on the agenda. It needs to be put up or distributed, and every single action item needs a status report on where we stand with respect to the initiatives that were agreed upon by the group to be undertaken. Now, some may die a quick death because we investigated it, we couldn't do anything, but it has to really be a part of a regular meeting process, regular discussion process, regular distribution of information to all the parties, and then management obviously has to own it, and because usually management has most of the responsibilities for the execution of the action items. So what we see is, we have to execute, and the way we execute is we put it up. Now, one other thing that makes sure that that it's getting followed is, I think many of the managers, a lot of the ones that we know, would say, what are my annual targets for my evaluation of my job performance? Well, a lot of times the completion of the task, which as Jeff pointed out is typically a 1-year plan, ends up being the primary metrics available for performance evaluation. These were the 12 things that we were tasked to do. The management team, the CEO, the administrator was usually the lead on most of those. So did we accomplish them? Did we not? We did. Therefore, the evaluation of my performance should, be reflective of the fact that we executed everything on the out of the strategic planning meeting.
Okay. So could either of you give us kind of an example of a strategy that might come out of a plan and how manager might stay on top of it during the year?
I can answer that, Kara. One initiative might be to work on some recent examples, streamlining the patient throughput on the clinical side of a practice office. Oftentimes you find out about issues when you see patients actually getting out of exam rooms and leaving because the wait time is too long, or they just get frustrated. So one action plan might be to go through an exercise where you've involved every staff that touches the patient in that process, and you're tasked with analyzing that workflow, working on operational improvements. What is driving the scheduling issues? Is it a physician preference or a physician mandate that we schedule a certain way, and the physician is not necessarily living up to their end of the bargain that they've put in place with the staff? So we're loading up patients in sub-waiting or in the exam rooms, and we know we're not going to be able to get to them for an appropriate length of time. So actually putting that plan in place, having definite time frames attached to it, resulting action plans and expected action plans coming out of that work group, and then as Mike mentioned, keeping that in front of your executive committee, or depending on your size, it may be your operations committee or some other group, and measuring actual implementation. And ultimately, with a project like that, you're going to want to measure your patient satisfaction and also your wait times in sub-waiting and exam rooms, and patients walking out the front door, which you don't want to see.
Yeah.
You know, another example of that, which will be a little bit in the more nebulous category, which is a little bit of where we're operating today under alignment. It could be two examples there. One is we really want to keep our ear to the ground on what's going on with other groups in the marketplace. So you could organize a monthly meeting rotating through the offices of the larger groups in town that may not be affiliated yet. So it may be the OB-GYN group, it might be the ENT, it might be the general surgery group, the urology group. But you get scheduled a regular monthly meeting. It could be in your office this month, somebody else's office, but a constant meeting on the calendar that reports back as to what other groups are doing strategically. The second category there would be scheduling your regular meeting between you, the president, and the CEO of the hospital that you work with, or if it's multiple hospitals, making sure that you're having regular meetings with hospital executives at a high level, and as we like to say, constantly asking, well, what can we do to help? What do we need to do to work with you? What do you need most from us? And so that would be, again, nebulous. It doesn't necessarily have at each meeting, and these are the harder parts of planning right now. There's not necessarily do this, get this out of that particular process, but it's the constant information gathering, relationship building that is necessary in the environment we're in today. So that would be two examples on alignment initiatives that will take time and take patience because there's not an immediate result from those activities.
Another comment, Kara, and this is a big difference we see between strategic planning and execution within physician groups versus hospital systems, and it becomes more and more of an issue as we see physicians aligning and affiliating with hospitals and reconciling those different cultures as you come together. Within a physician group, it's often very beneficial to try new initiatives and reward those that have innovative thoughts, creative ideas, try to put processes in place to try new things. And in a physician practice, if you fail at something, you shouldn't necessarily take them out back to the woodshed, and we encourage rewarding folks for trying and not necessarily succeeding all the time, but coming forward with those ideas, trying something new and innovative, and if it works, great, and if it doesn't work, we try to figure out why it didn't work, and we learn from it and move on. Whereas over in a hospital culture, having an initiative fail can be much more career-altering, if you will. So there's a big difference in those cultures, and there's a lot more hesitancy. And you see that as you work with hospital systems to try new, creative, fringe, on-the-edge type of ideas, just because there's a little bit more reluctance to go down a path that might result in what you could consider a failure, whereas in a physician practice, that's a normal thing. You learn from it and you move on.
That's great. Thanks for sharing those ideas. So what we start to see is that the plan would have the higher level initiatives, and then each level of the organization is going to be involved somehow in carrying through their detailed action plans and finding out, what they can do as far as results are and monitoring and reporting that in. Mike, are there certain times where you'd actually address the plan mid-year and try and change it? Like, what might prompt that?
Oh, clearly. I think it's really interesting. We're in a really dynamic time for healthcare. So your market could change overnight with an affiliation between hospital systems, one you served, one you didn't, a merger of groups in your marketplace and you're on the outside looking in, a group selling or aligning with a hospital that may be the first, and now all of a sudden you start looking around for the other dominoes to fall and you're going, well, hold on, so the plan that we came up with now could require some dramatic changes. So any types of movement, provider activity in a marketplace would really suggest that you've got to be back at the table analyzing it. Now, it'd be nice to think in the planning process those possibilities or issues were discussed, but sometimes they're not, because we don't necessarily have the intelligence to know that those people are talking or are even considering some type of alignment, but those things that, again, require that you get back to the table. Now, you could obviously have the sustainable growth rate issue come crashing down on you where we don't have a fix. You could have a change in what the payers are doing. It'd be interesting to see what happens with WellPoint Anthem's goal to increase payment to primary care, focus on patient-centered medical home, and where we're going to find the hours in the day and the number of primary care physicians to do all that may be required to see that. So I don't know if there's an opportunity for specialists to look at what care should they be talking to the primary care physician about in terms of redirecting their way instead of saying that belongs in the. So, payer changes, hospital changes, group movement in the marketplace, all would suggest we better get back to the table.
A couple other examples that can come up that can really impact a group's strategy and execution can be, for example, in diagnostic imaging, the significant cuts for multiple procedure payment reductions, or MPPR payment reductions, which CMS is pushing over to not only the technical component side of imaging, but also the professional side, which has impacted professional radiology groups. Another significant event that can occur is over in orthopedics, general surgery, neurosurgery, significant changes in the call panel or willingness to participate in call, especially for those that are level 1, level 2 trauma centers. And if you have a significant departure of a group of physicians that take the preponderance of call, either outside of the market or just going off call, then that can really impact how a group functions and operates. It can impact how you do your clinic schedules. Depending on the call burden, it can really impact how the physicians function post-call, and can ultimately impact OR blocks. In some systems, moving around OR blocks is not a huge deal. In other systems, it's like trying to move the earth to get different OR block schedules. So things like that come up have to be addressed throughout the year as they happen.
As we think about the plans that you've seen, built and created out there in the healthcare practices, can you think of some examples where they did it really well? In other words, they planned well and then they stayed on top of it well. And share kind of what were they doing in order to be good at that?
Boy, you got to be careful of mentioning one and not mentioning the others that you've done planning for.
And there's also probably an element of some really outstanding results that we've seen where luck and politics had a little bit to play with it as well. So sometimes it just helps to have the timing down. But one in particular that comes to mind was an orthopedic strategy that we worked on with a group, working on an alignment strategy with our hospital system, really helping to build a better relationship. And ultimately, again, due to timing and politics, they were able to evolve that into a orthopedic specialty hospital type of initiative, joint venture, when you could still do those kinds of things. So And that's just a good example. Again, luck was on their side and timing to a large degree, but by working on that initiative as a very conscious effort, we went through 2 particular very distinct starting and stopping points, trying to work with that system. We're able to finally get a good relationship going, improve the relationship substantially, and over a period of a couple of years, evolve that to a much more pervasive and significant type of joint venture. But without the vision that group had and without the effort that went into it to not give up, to keep going back to that hospital system, working with them because they really felt like strategically that was the ideal system to align with, they wouldn't have been able to get to that point even with luck and politics on their side.
One of the better processes that I've experienced, which I give real credit to the leadership team, was we finished the physician side of the planning retreat with the key leaders, and they invited us back 30 days later for the senior management retreat. And the goal was to present at a high level what the physicians had agreed on, avoiding any discussion of anything that might be deemed confidential in the action plan or create fear. And after that discussion, senior leadership kind of created the David Letterman show, where each team lead then created their top 10 strategic initiatives for their area that was going to be an action plan to support the physician. Then each team lead took their top 10 back to staff and had their own little staff meeting. So what we had was complete engagement of the entire organization, bottom up. And I say bottom up, it started at the top, but now I got everybody engaged all the way down through the organization. And so it was a great way to get everybody involved. And it was fun to be a part of watching senior leadership take the physician plan, build their own, step it down to their own team members, and get everybody engaged. I thought that process probably was one of the best ones that we've seen, from the physician process all the way down to the staff level. So I think that was, when you talk about effective, I think that's an effective way to get 100% buy-in to where an organization is headed. It communicated what was going on, kept everybody in the loop, informed, eliminated the fear aspects of what's happening in the environment. So it was really powerful, I thought.
I can give another example. We worked with a gastroenterology group a few years ago, and this was at the time when many endo centers and GI groups were going towards hospital affiliation. There was a lot going around. This was kind of at the tail end of the under arrangements era as well. There was a lot of initiatives around the country on converting those endo centers to hospital-based, trying to enter into management agreements or affiliation agreements with hospitals. And we were working with a group that had been growing fairly significantly. They were struggling a little bit with some of their investments they had just made. There was some doubt going throughout the ranks, including the physician ranks, as to whether this was the right strategy to pursue. We helped the group go through a fairly detailed financial analysis and projection out of different scenarios, and we did it in a formal and structured fashion and had all physicians present when we were going through those results and exploring the pros and cons of the different options. And ultimately, we like to cheer for this one. The physicians decided to stay the course. They put some time frames in place. They had some measurable progress that they had all agreed to that would be acceptable and that they pursued. And ultimately, they stayed freestanding for their centers and were ultimately very successful and achieved profitability levels far beyond any of the wildest projections under the hospital affiliation scenarios. So we were really encouraged by that, and you have to cheer one for the independent side, at least in that type of scenario. But it happened through a structured analysis and thoughtful planning process with goals that were established. Everybody agreed to time frames, what the measurement points would be, when we would make a decision as to path A or path B, and they stuck to it, and it worked very effectively.
It's good. It sounds like building the strategic plan can oftentimes be a way to open up your culture and the communication between, the leadership, between the physicians. What if things aren't going so well? Have you gone into situations where your your strategic plan, you want to build it, but yet there's some, the culture is not right for it. Have you had to work with that environment?
Well, the answer is yes, and the question is, if the culture is not right, then why is the culture not right? Which means you've got to go to the top of the organization and figure out what is happening at that level that has created or allowed for the culture not to be right. So then you're saying, I've got to fix the leadership, whether it's a health system, I got to fix the, it could be you got to fix the board who may not be involved, or I've got to get the physicians on board with where the organization is headed, or where it needs to head, and what's the culture that we need to create. And you know, we haven't talked about it, but I think one of the, we get into, whether we got payer reform coming, we got all these other things coming, but one of the, I think, most dramatic impacts on organizations and culture is the generational issue. Mm-hmm. And I think, I said in a meeting yesterday, and somebody asked, well, you know, where do you see things headed in 5 years? And you think reform's pushing it. And I said, I'm torn between payment reform and the generational influences as to pushing us where we're headed. And that generational influence is, you know, or the X, Y, whatever you want to call that generation, views the world differently. And so mixing that inside any organization, I don't care if you're a health system or whether you're a physician organization, and getting those people on the same page when they don't really have the same vision or the same goals or the same purpose. I look at our veterans and boomers who this was a profession, and I look at others and it's a job. Doesn't mean they don't do their job well, but they just have a different mindset about what it is. And so, and what's interesting, and I know we've talked to a lot of people about this, and some can see it, you know, you're kind of just going along and you see a little bit of the trickle effect of that generations, but you know, as 1 or 2 docs retire and 3 or 4 more of the new generation joins, you can have a pretty quick flip in the entire culture, and culture is probably the best word of that organization. And now I'm really mixing things that don't necessarily mix together. So that really has to be addressed, and that unfortunately is where you spend time on some of the soft elements of mission, vision, values, which again are not things physicians for sure find much benefit of, but which are pretty important. So Karen, going a long way about saying you got to start at the top of the organization, because how they view the world, how they act, the vision they've set trickles all the way down. And so if you see a place that's got kind of a not so good culture, you don't have to look very far to figure out why that culture is the way it is. And then the challenge is, can you fix it? And I think just figuring out how to go along and get along is still like, is there a time bomb ready to go off there at some point? So we've got to do more than just figure out how to get along or go along. So, and huge challenge.
Another area where we see that come up, oftentimes one of the outcomes of a strategic planning process might be to pursue or investigate affiliation with another group, whether it be in town, across town, or across the county. So a physician-to-physician affiliation is often a strategic initiative. Those do take some time to work through, and it has happened more than once when you get into those discussions with other groups, that it comes down to the primary barrier being a difference in cultures, and that can range from how the governance operates to how the compensation plan works, and just to how the partners treat each other within different groups. And oftentimes, we discussed internally here in various markets, there's a reason why there's different groups, and that's because there's different cultures, and as you go through the recruiting process, you tend to perpetuate the culture that the group has. And when you try to bring 2 groups together that have significantly different cultures, oftentimes that can be the end point, and that's one of the primary reasons why we try to address that in the merger projects we work on more towards the front end of the process, because that may make or break the remaining discussions on a physician affiliation.
Well, it's been good to have your perspective and share some of your experiences today on the phone, and you know, we appreciate the bits of knowledge you've shared with us to this point. We'll give it a few more minutes and open it up for questions. At this time, if you'd like to ask a question, feel free to type that into the chat box on your screen, and then we'll be able to send it through to Mike or Jeff and have them answer. At this point, we don't have any questions from our crowd, but we will, again, we'll stay here a few more minutes and see if there are any questions coming through. We appreciate your time and interest today on the phone. If we can answer any questions, you've got our contact information there. Please feel free to reach out to any of us, and we'll be happy to help.
Kara, as we're waiting to see if any questions come in, one of the other thoughts that we had during the discussion today was in keeping track of progress throughout the year and some of the different tools that we've seen to utilize that. It is oftentimes good to have some sort of balanced scorecard or what I call a KPI dashboard or key performance indicator dashboard. And you can incorporate into your dashboards or KPIs some of your strategic planning initiatives as well. So it's good, especially for those that take a longer time to implement, so it's not all going to be done from one meeting to the next, but you can measure your progress and report on that progress, and especially if you're on track and you can make one of your boxes green versus yellow or red where we're falling behind or we've run into some roadblocks. That helps keep those strategic initiatives and even tactical plans out in front of your executive committee and your operations committee. In addition to those other KPIs that groups need to be monitoring, especially with the ACO world and other initiatives that are out in front of us. So we do like to see the use of those dashboards or monthly report cards.
Yeah, and so you could ask the question as you're developing then each strategic initiative, you know, how will we measure or monitor this throughout the year? How are we going to know we're getting there? And build that into your scorecard, as you say.
Exactly.
Okay. We do have a question here, and that is, will you guys be presenting at any association conferences this spring?
Let's see. We have, at the AAOE conference, we have three presentations. We have one on strategic planning in the current environment. We have one on alignment strategies and models in the current environment. And we have one on service line co-management as a specific strategy to deal with, and that's at AAOE in Louisiana. We have a presentation at the California Orthopedic Society on strategic planning. We have a presentation at the Maryland Orthopedic Society on strategic planning. We have a presentation at the Indiana Orthopedic Society on the state of orthopedics and what's going on around the country.
I believe that's about around April 20th.
Around April. The California meetings are the same week of April as is the Maryland meeting. And AAOE is in May in New Orleans, I believe.
And I will be presenting the session on service line co-management and with a particular emphasis on structures and strategies to really focus on the various ways those types of hospital physician initiatives can be structured and really strategic approaches to developing that type of relationship. A lot of that depending on where your hospital system is in the process and their knowledge base of service line co-management and how can you work through trying to build an affiliation through different sets of circumstances.
We have another question from one of the listeners that says, do you have a sample of a questionnaire to use as a survey?
Well, we have a proprietary tool we've developed over time that's probably, it's about 39 pages of questions right now that's brought, you know, a lot of space, it's not single-spaced, that have kind of evolved with each retreat, with each set of issues that come up. That we use on a regular basis. I say proprietary. I mean, everybody probably has their own set of questions. So if that person wants to contact us directly, we can discuss how we might be able to share with them how we utilize the tool.
And one of the key points there is that I always caution against trying to use a template too much, you know, not being self-serving in the response, but really if you focus on the 7 or so primary areas that Mike discussed earlier, the mission, vision, values topic, the physician issues, which can include governance, culture, compensation, call, et cetera, the growth, practice growth areas, the alignment areas, quality, and that's clinical quality, patient satisfaction, et cetera, as well as operations, and then facilities. If you use that as an outline and then start to filter through that, and typically we'll take multiple iterations, and that can be a shared document that's passed around or an email, where you're really polling your group and what your specific issues are in each one of those areas, rather than necessarily going to more of a canned type of questionnaire, which can be dangerous at times. But even when we're working off of our starting template, we're really making it very specific and tailored for each group and each group situation, trying to meet what's going on in the marketplace and with that particular group culture, those particular physicians. So starting with that outline, getting the major headers down and going back through and starting to come up with some major points, and then oftentimes you'll have some sub-points or various threads that will evolve off of those initial outlines. That seems to be the best way to truly build a really meaningful survey for each particular group.
Thanks, Jeff and Mike. We have one more question. Is there an organizational structure that lends itself better to executing a strategic plan?
Oh, I have to think back to my days in practice management when we would joke that we were led by the benevolent dictator, and that seemed to work pretty well. So I don't know that there really is an ideal plan or ideal type of structure. A lot of that depends on group size and group culture, and oftentimes that's a difficult point to get to within a group, especially as Mike alluded to, with the generational differences that are coming through the groups, with physicians coming out of school now, which can really start to change the dynamics of a group culture. Overall, I think we would say an open type of approach versus a closed and proprietary. It tends to be one of the key determining factors in a successful structure, regardless of specifically how it's put together. When we go into groups where even things like individual productivity is a closely guarded secret, and no one trusts the numbers they see, and there's a lot of rumors and urban legends going around the group versus open and transparent reporting and facts. We think that's one of the key differences in groups that have a successful governance structure and execution strategy in place.
Yeah, when I look at structure, if I look at what I call a standard structure of the shareholders elect an executive committee, and the executive committee basically is charged with the day-to-day functioning of the group, and they may have subcommittees such as operations and finance. And most of the administrators who are participating today that have done planning will realize that the most effective structure is they're on the task list for most every item in conjunction with their president or their executive committee. Most of them walk out and say, well, we had a good weekend except for all the tasks were given to me. And unfortunately, that's really where most of it ends up. But you need executive committee support, president support. As Jeff said, I think that has to be shared on a regular basis. The shareholders have to be updated either through internal email communications or through the quarterly shareholders or every other month shareholder meetings. It's often difficult to have a strategic planning subcommittee because oftentimes the executive committee takes ownership of everything, and therefore they get a little bit, I don't know if off-center is the right word, when somebody else is running with all these strategy things that the executive committee often finds or feels as their responsibility. So usually the domain of execution is with the EC. Yep. And that's usually the structure with the CEO or administrator having the highest percentage of individual tasks, as well as really being responsible for making sure it all happens. That means pushing our president, pushing our executive committee, and pushing for up or down decisions. When the research has been completed as part of the planning process, and now we need to go left, right, or down the middle. Right. So that executive leader driving the effort involved is critical. Yep. And then clear communication throughout the process. Yeah, the communication thing's interesting, and people that know us, we usually say this, when we do our own, we do questionnaires for a group practice, the #1 weakest area in all the questionnaire responses over all the time we've been doing it is communication. So And even as you make efforts to do it, it probably still will come in as the weakest item because I didn't listen or I didn't read what I was supposed to. So the communication process is critical. So when you think you've done it enough, do it twice more.
Yep. Yep. Well, I think anybody in the organization wants to know where are we going and what do you expect from me to get there. And so it's important to keep communicating that vision, that plan, and keep it out in front of everyone so we know that our actions are leading to the result that's wanted. Well, again, I will close out today's session. We don't have any more questions. We'll let you all go a little bit early and grab some lunch. And we appreciate your time, as well as Jeff and Mike. Thank you very much for sharing your knowledge with us today.
Thank you, everyone.
Thanks for your time.